Bonjour à tous et
Hello,
bienvenue
everybody,
à
and
l'événement
welcome
Parlons
to
Recherche
the
organisé
Let's
par
Speak About
l'association
Research
Parkinson.
event
C'est un vrai plaisir de vous trouver
organized
aussi nombreux
today,
aujourd'hui
and
dans
we're
cette
very happy
magnifique
to see
salle de
you
la Recherche Arena.
in such
J'espère que
large
vous avez pu
numbers.
profiter
I
des espaces
hope you
découvertes
could enjoy the
et regarder
discovery
différents stands
space and look at
d'activités qui
all
s'y
the
proposent.
activities. If you
Si
haven't
vous n'avez
had
pas eu le
time, it
temps,
will
ce
be
sera encore
open
ouvert après. Vous pourrez
later, so you
toujours
can always
faire un
go
petit tour
there
des locaux
later.
après.
This is the
Donc aujourd'hui,
first,
c'est la quatrième
fourth
saison
edition, sorry,
de
about Let's
Parlons
Talk About
Recherche. Ils ont toujours
Research.
fait des
You
belles
know, good
saisons, elles
seasons
recommencent,
need
on
to
a
be
envie de les
repeated,
revoir.
and this will be the
Donc
fourth
voilà, c'est la quatrième
edition.
saison.
It's the
C'est le
first
premier épisode de
episode, the
cette
first
quatrième
stage
saison
of
avec la
the new
thématique
season. The subject is
Parkinson et la
Parkinson
recherche
and
clinique.
clinical
Donc un sujet
research.
très
And
important.
today we
Et
have
aujourd'hui, on
two
a la chance
neurologists
d'avoir
with
deux
us. We're very lucky.
parlologues
They come from
avec nous
different
aujourd'hui de
backgrounds and
différents
places in
endroits de
France. They're going to
France
talk about
et qui
different
vont aborder
disorders
différentes
associated
troubles
with
de la
Parkinson's
maladie de
disease
Parkinson
and tell you what
et vous
research is
expliquer ce que
doing
fait la
for us to
recherche pour
understand
mieux comprendre
these
ces troubles et
disorders
mieux les
better,
détecter
to
et mieux les
treat them
appréhender.
better.
Donc dans
We
l'ordre
will have
passage, on
Dr.
a d'abord
Pauline
le
Daudet,
docteur
a neurologist
Pauline
at the La
Daudet, qui est
Pitié-Salpêtrière
neurologue à la
Hospital. She's an
Salpêtrière,
expert
qui est
in
une
sleep
experte
disorders. She's going to
du
talk about
sommeil.
a
Elle nous parlera du
trial which is in
dispositif dans
progress
plus
in
de
several
200
centers in
France
France to
pour
better
mieux
understand
trouver les
sleep
comportements dans
disorders.
la maladie de
Then
Parkinson.
we will have the local
On aura après le
representative,
local de
Pascal
l'ESAP, le
Defkinderen, who's a
professeur Pascal
neurologist at
Defkinderen,
the
qui est
Nantes
neurologue au CHU
teaching
de Nantes et
hospital,
professeur à
and he's
l'université
going
de
to talk
Nantes.
about the
Il nous
connection
parlera du lien
between
entre
the
l'intestin
gut
et le
and the
cerveau dans
brain
la
in
maladie de
Parkinson's
Parkinson.
disease. And
Et
finally, there will
finalement, on
be
aura le
Sarah
docteur
Meoni.
Sarah
She comes
Meoni
from
qui
the
vient de la
Alps.
région des
She
Alpes.
works
Elle
in
travaille à l'unité
a
des troubles du mouvement de
unit in
Grenoble. Elle
Grenoble
nous
about
parlera
motion
d'un sujet
disorders, and she
souvent
will
ignoré,
talk
c'est
about the
l'influence
menstrual cycle
psychomédicale
and
chez la
the
femme
relationship
sur les
between
symptômes et
symptoms
sur
and
l'efficacité
efficacy of
des
medication. So we're
traitements.
going to start.
Donc, on va bientôt
Just a
commencer,
few
juste quelques
housekeeping
règles.
rules. The three
On aura les trois
speakers will take the
présentateurs qui vont
floor
parler
in
chacun
turns.
à leur
We
tour.
will have
On a
questions
prévu des
at the
questions
end
à
of
la
the
fin
presentations, so you can
présentation.
ask
Donc, vous
questions at
pourrez
the end of the
poser vos questions
presentation. There are
à la
many,
fin.
many
Il y a
people
aussi
following
beaucoup de
us
personnes qui nous
online,
suivent en
and
ligne
thank you for
aujourd'hui. Je
those
les
following
remercie d'être
online for
connectés
being connected.
en ligne,
You
mais aussi qui
have
auront
access
accès à
to
ce
the chat,
chat
and you can ask
et qui peuvent nous
questions
poser des
directly in
questions
the
en
chat
direct
function.
de la chat.
Now, you
Je vais
have
vous
seen
demander si
QR
ensemble, donc
codes
vous avez vu des QR codes,
around
les QR codes scotchés.
posted
En
on
fait, vous
billboards.
pouvez poser
You
des
can ask
questions aux
questions, but
chercheurs
you
et on va
will
aussi vous
also
poser
be
des questions.
asked
Entre
questions.
chaque
Between the
orateur,
speakers,
on
we
vous
will be
posera une ou
asking
deux
you
questions.
questions
Déjà
just to
pour vous, pour
understand
voir
whether
si vous avez
you
bien compris.
you
Le but, c'est
have
aujourd'hui de
understood
vulgariser la
the
recherche et d'être à l'accessibilité.
presentation to make
Donc vous
research
aurez des questions
available
auxquelles vous
to
pourrez répondre à travers
accessible to
votre
everybody.
téléphone et on
And
reviendra
then we will
là-dessus
come back to these
après aussi pendant
polls after the Q&A
partie
sessions.
des
So without
questions.
further ado, we're
Donc sans
going to
plus
start
tarder,
with
on va
Pauline
commencer
Daudet.
avec le docteur
Thank
Pauline
you for
Daudet.
being here, and
Merci
you
d'être
have the
là et
floor.
je vous en prie.
Good afternoon, everybody. It's a pleasure to be here with you today to introduce this research project, the relationship between sleep and Parkinson's disease. I'm a neurologist, but I'm also very interested by sleep. So I have connected Parkinson's disease and neurology and sleep. We work in the La Pitié-Salpêtrière in the sleep special ward, a dedicated unit. Now, Parkinson's disease, there are motor disorders and motor symptoms, the symptoms that will lead the patients to see a doctor, but we also have non-motor symptoms which can be invalidated in neuropsychiatry, sleep, sensory, cardiovascular, gastrointestinal, but mostly here I would like to focus on the sleep related symptoms because these symptoms are very frequent. 70% of the patients complain of sleep related symptoms during their disease. And it's important that we document and understand those symptoms to be able to manage them. There are different types of sleep disorders that I'm going to explain later. Now, why do people suffer from sleep disorders in Parkinson's disease? Here we have a section of a sagittal section of the brain, and we have some red dots, and the red dots show the networks that are directly involved in vigilance when we're awake, when we don't go to sleep. Or they also make us go to sleep when we're supposed to, i.e. at night. This is a fairly complex picture, and I have added little pictures showing deposits that can be found in some very specific places, and those deposits lead to sleep disorders, which I'm going to explain. The vigilant
Donc,
sleep
ce système
systems
veille
is
sommeil,
relatively
donc
complex, so we
déjà, il
will
faut déjà
not
s'en
go into too
occuper,
many
mais
details,
veille
but it
matin,
can be
midi
involved very
et
early on in
asynchrone aussi, hein,
Parkinson's disease,
et
leading to a number
il
of
va donner toutes
symptoms,
sortes
such
de
as
symptômes, et
a
notamment, il va
bad
pouvoir aller
sleep
déstructurer
structure.
le sommeil, ce
The
qui va
sleep structure will
entraîner
be
à la
disrupted and
fois
people will
des
suffer
troubles du
from
sommeil
sleep
pour les patients
disorders
dont ce
and
demain,
complain about sleep
et
disorders.
ces
And the
structures du
sleep
sommeil, on
structures
va
or
pouvoir
schemes
aussi
can also
aller
be
les
analyzed,
analyser, aller la
documented,
documenter
in
pour
order
voir
to understand
justement
whether
et
this
prévoir
may
aussi qu'il y
lead
ait
to other
d'autres indications
indications, for
pendant
instance, for
les
prognostic
recherches,
purposes.
notamment pronostiques. On sait également
We also
que le
need
sommeil
note that
va
sleep
avoir différentes
has a number of
fonctions.
functions.
Le sommeil, il
Sleep
a un
plays a
lien
role
notamment
in
sur,
memory,
enfin, il a un
or how
rôle dans
to
la
remember
mémorisation.
things. If you
Donc
sleep
bien
well, you
dormir, ça
remember
permet
well,
de bien
or you
mémoriser,
memorize
mais
ideas.
il a peut-être
And also, it may have a connection
probablement un lien aussi dans tout ce
with
qui va être
toxin
élimination de toxines
elimination, toxins
au
being
cours
cleared
de la
during the
nuit,
night,
et donc
and there
avec
is
un
therefore a
potentiel
potential
effet
neuroprotector
neuroprotecteur.
effect of
Donc
sleep.
finalement, on voit
Sleep
que le
can
sommeil va à la fois
show
donner des
symptoms,
symptômes,
but sleep
mais
can
aussi va
also
pouvoir
be a
être un
marker
marqueur
which we
qu'on va
can analyze,
pouvoir analyser.
and the sleep
Et aussi,
structure
la
itself,
structure du sommeil en
or rather,
elle-même
the
va
fact that
pouvoir,
the sleep structure is
cette altération
disrupted,
va
will
pouvoir
lead
entraîner
to
une
sleep
altération
functions being
des fonctions du
altered. And
sommeil,
that
avec
is very
vocation
interesting.
à
That's an interesting set of
mieux
data for us neurologists
caractériser.
because we need to characterize those issues. So, well, how do
Alors,
we
comment on
study
étudie le
sleep?
sommeil?
Maybe some
Je
of
ne sais pas
you
si
have already
certains d'entre vous ont
done
déjà eu
sleep
des entretiens de
recording.
sommeil. Il
There
y a
are
deux
several
aspects,
things
bien
here
sûr,
when you deal with sleep
prise en charge
disorders and
du
patients
sommeil.
suffering from sleep disorders.
Bien
First of
sûr,
all,
il y
the
a
interview,
l'interrogatoire
and the patients
avec
will
des
report a number
symptômes
of
que vont
symptoms
venir
such as
rapporter les patients.
insomnia,
Insomnie,
or in blue we have somnolence during the day,
le syndrome du ventre
the
clos, donc les impatiences
so-called
éjaculatoire
restless leg
qui nous
symptoms,
empêchent
which will stop you from
de
going to
dormir,
sleep, and sleep
l'agitation la nuit, ce qu'on
agitation or
appelle le trouble du
paradoxical
comportement
sleep
au sommeil atypique,
disorders.
qui va être présent
And
chez certains
this can
patients
be observed in
et peut
some patients,
même
sometimes
commencer
years
des
before
années
the
avant
motor
que les
symptoms appear.
symptômes
This
moteurs
is what we call the
commencent, ce qu'on appelle
prodromal stage.
instable
And
trop mal,
finally, sleep
et
apnea.
puis des apnées du
All of
sommeil.
these
Tout
signs
ça
and
va
symptoms
donner des
can be
symptômes qui
listed
vont
and
être
reported
rapportés.
by the patient.
Et à côté de ça,
And
on
then
va
we will
avoir un
perform what we
enregistrement
call a
du sommeil
sleep
qu'on va faire.
recording.
Donc
I'm showing you a
une
picture here
photo
of
de
someone
quelqu'un
sleeping,
qui
a lady
dort. Il y a
sleeping with
différents
sensors
capteurs, vous voyez, au niveau
positioned on her head, on
positionnement au
her
niveau de la
eyes,
tête, au
on her
niveau des
chin,
yeux, au niveau
on
du
her
menton, sur le
respiratory
niveau respiratoire.
organs.
Et tous
And
ces
all
capteurs
these
vont enregistrer
sensors
des
will
signaux
record
qu'on va
signals.
coder,
And
qui vont
we
donner
have an
un
electroencephalogram,
électroencéphalogramme
or
ou
we also have ventilation being recorded.
des
There are
informations
information
sur
on
la
her
respiration,
breathing being
etc.
recorded.
Donc
And
l'enregistrement du
during
sommeil
the
qui dure
night,
toute la nuit va être
the
vraiment un
recordings
examen
will be
qui est
extremely interesting
intéressant
because they
pour
will
aller
tell us exactly
capter
what is happening during
finalement
the
ce qui se
night.
passe au cours de la nuit
And
et
they will tell us
le
whether the
bon
brain
fonctionnement
is
cérébral.
working correctly.
Sachant qu'au cours
During
du sommeil, on va
when we
avoir
sleep, there are
différents stades de
several
sommeil.
stages.
Donc ici,
Here I'm
vous
showing
avez
you
les
the different
différents stades. C'est
stages.
juste pour
It's
vous montrer la
very complex.
complexité
The
de
waves
ce
we
qui peut
record are
enregistrer.
extremely
Vous
complex.
avez en haut,
At the
sur la
top, we
partie
have
haute,
vigilance.
la
So the
veille.
patient
Donc c'est un
is
patient qui va
awake.
être, enfin n'importe qui va être avec les yeux fermés,
Sorry,
dans
it's
un
not
état
awake.
alpha.
It's the vigilant
Et puis
phase. The
ensuite,
eyes
on
are
va
closed, but there is an
s'endormir.
alpha
Et
kind of
l'activité
wave. And then
cérébrale, en fait,
the
elle va se
brain activity
modifier
will
au fur et à
change
mesure des stades de
during the
sommeil.
night.
Vous voyez,
There are
en
N1,
fonction du stade
N2, N3
N1,
stages, and
N2,
depending on the
N3,
stage,
on n'aura pas la
the
même
curve will be different. The
électroencéphalogramme. Et ça, c'est
electroencephalogram
lié en
curves
fait
will
à
be
notre
different because the
activité
brain
cérébrale
activity
qui va
changes
se
during the night.
modifier au cours de la nuit.
During
Par
the
exemple, vous
N3
voyez qu'au
stage, we have
stade
some very
N3, on
slow
va avoir ces
waves
ondes lentes, donc ces
looking
grandes
like
espèces
sea
vagues comme
waves.
ça. Et ça, donc,
And
c'est
this is
un
the
stade
stage
qui
during
permet
which
une
we
totale
recover.
récupération. Et on pense peut-être que
And
c'est à
we
ce moment-là
believe
que
that
se passe
it is also probably
l'inhibition,
when toxins
l'élimination
are
des toxines.
eliminated
Donc, tout
and
ça, bien
cleared from
sûr,
our
est
nervous system.
quelque chose qu'on peut
That can be
enregistrer,
recorded,
mais provient
but
finalement
it's
probablement
most
de
likely that
l'association de
we
deux
have
neurones
neurons here
qui vont aller
that provide
donner
those signals that can be
ces
analyzed.
signaux et qui vont pouvoir
The
les
last
analyser.
wave is what we
Vous
call
voyez le dernier qui est le
paradoxical
sommeil
sleep.
paradoxal.
Now, that is a
Donc ce
very
stade, c'est
special
un peu
stage, and this
particulier.
is
C'est là
where
où se passe le
we
sommeil.
have
C'est
behavior
paradoxal. C'est là
disorder
où en fait les patients vont
issues
parfois perdre
because
la tonique
some patients will
physiologique du
lose
stade.
the
Normalement, on n'est pas
tone
habitué, mais un
and
processus adaptatif qui
the tonic
empêche
control
les bras
during the
et les
sleep,
jambes
and
de
they are no
bouger.
longer
Donc, on va avoir certains
sort of
patients qui
paralyzed,
vont
and they will
perdre leur
start
haleine,
dreaming
qui
and
vont
moving around in
même
bed and
parfois
be
être
very
assez
agitated, and sometimes they can hurt themselves. They can either hurt the spouse or fall from the bed. The main sleep disorders. No, the most prevalent one is insomnia, the difficulty to sleep. The fact that it's difficult to sleep through the night. You go to sleep, but then you wake up after a couple of hours and you have trouble going back to sleep. So you miss the last cycle. Prevalence between 20 and 80%. So it fluctuates a lot depending on the trials and the studies and how insomnia was defined. Then we have excessive day somnolence, people who go to sleep during the day. And again, prevalence is 16 to 74%. And it's quite disturbing because it can be very disturbing for your day life. Where you go to sleep when you're watching TV, you go to sleep when you're reading. But in the worst cases, you may go to sleep while driving. People can resist the somnolence, but sometimes there's nothing you can do. You just go to sleep. And if you're driving, that can be extremely dangerous. And finally, we have the paradoxical sleep behavioral disorders, people who live their dreams very actively, and that the prevalence is between 25 and 48%. Now, I'm showing you the main disorders, and these sleep disorders are not constant. They can increase depending on the alpha-synuclein deposits that will increase in the brain tissues, and they will increase that, they will disrupt the sleep vigilance system, and they need to be monitored throughout the patient's life, and it's possibly very debilitating for the patients. Here, the study was conducted in patients in the early phases of the disease, first 3 years. 40% of the patients already were complaining of insomnia, 25% complained of behavioral disorders during paradoxical sleep, RBD in English, and somnolence 25%. Restless legs syndrome, no difference from the controls, and sleep apnea. Well, the patients with PD did not have more sleep apnea than the control subject. So it doesn't seem to be associated with Parkinson's disease, simply because the patients are often aged and elderly, and that's the reason why we observe sleep apnea. There can be, the symptoms can be mixed together, insomnia with somnolence. And for doctors, it's very important that we characterize all the disorders, because sometimes they're connected, but sometimes they aren't. Regarding polysomnographic recordings, so far we didn't have much in terms of correlation. Mostly it's a clinical diagnosis. We don't know whether insomnia in Parkinson's disease is similar to the kind of insomnia we may observe in general population, and whether there are any specific markers recorded in polysomnography. For somnolence, it's slightly different. In the studies we conducted, we found no connection between what was happening during the night and what was happening during the day, i.e., nighttime sleep quality was not connected with somnolence during the day, which may be quite surprising, because if you don't sleep well at night, obviously, you tend to fall asleep during the day. And finally, for RBDs, we know that we have a loss of atonia during sleep, paradoxical sleep. So that's a very good way to diagnose the disorder. Our study that we have thought through before we started it is called SUMPARC. It's funded by the France Parkinson Association, and it provides answers to all those questions that I have just asked in PD patients, but also patients who suffer from isolated RBD, and patients who could be in the prodromal stage before the motor symptoms appear. And the objective of the study is to conduct a very exhaustive study of all the sleep-related symptoms in a large panel of patients, recording their sleep behavior in a very accurate way. It's never been done before, at least not at that scale. And we thought that we really had to have a very broad view on sleep disorders. We tried to provide answers to a number of questions. Patients report insomnia very often, so we try to understand when exactly during the disease course it appears. Are there motor issues? Is sleep perception altered? And we know that insomnia in the beginning of the disease may have different causes, but not in the middle of the course of the disease. And also sleep perception is important. I'm always struck because sleep recordings show that sleep is fragmented, but very few patients report that if we compare with patients who suffer from primary insomnia outside of Parkinson's disease. So it's interesting that there is a difference here in the sleep perception. And finally, we have the consequences for the spouse. It hasn't been studied so far, but sleep disorders in patients can have a huge impact on their spouses and also the spouse's sleep. We also wanted to look into somnolence, characterizing somnolence. Night and vigilance have to be considered as one big day, 24 hours. And the day is directly correlated with the night. So we conducted several tests I'm going to introduce so that you have a good picture of everything we've done and what the 24-hour cycle can look like. Finally, we also looked at the connection with concentration deficit. We thought maybe this could lead to cognitive issues and concentration deficit. We also looked at the restless leg syndrome, trying to characterize it because it doesn't show necessarily more at the beginning of the disease, but then with time, the symptom will increase. It may also be due to the medication, but we need to understand the physiopathology because it's different from the physiopathology we observe in patients with restless legs who do not suffer from Parkinson's disease. And finally, for patients who have the RBD, behavioral syndrome, in the prodromal phase, we want to understand whether their sleep is already altered at before the motor symptoms appear, because sleep also shows the brain functioning, and we try to understand whether some of the structures have already started being altered in the brain, and it shows through the RBD. And we try to understand the role played by microbiome and gut inflammation and the connection with sleep. This study is a multicentric study. Again, it's very interesting. Very interesting that we were able to work together on the national level, several centers collaborating. We exchanged on our practices so that we could homogenize our practices, and it provided us with a broader view. A large population of patients, 240 patients, 160 suffering from an isolated RBD, 50 controls, so people who do not suffer from Parkinson's disease. In total, 457 patients included in the trial. And the coordinating center was Paris, but we also had Nantes, Lille, Clermont-Ferrand, and Nîmes with specialized sleep disorder units. So initially there were a few challenges, but we were very happy that we started this year. Sometimes the regulation was difficult to manage. We started enrolling patients, 13 patients. We started in March 2025. Right now we have prodromal stage patients, but we are starting to enroll patients with already Parkinson's disease. And the other centers have started, are almost ready to start including enrolling patients because they have finally completed the regulatory issues. So how does it work? We have a large white mapping, and this is the protocol. The protocol is fairly short. Between the inclusion appointment and hospitalization, the inclusion interview is 1 day, and hospitalization is 3 days. No follow-up afterwards unless the patient needs to see us and has an issue that we need to see him for. And before the patients are hospitalized, they will undergo actigraphy. Actigraphy is a watch, like a connected watch, like an Apple Watch, that records the day cycle and the sleep vigilance cycle, what time the patients go to sleep, what time they wake up, how many times they wake up during the night, sorry. And it also gives us a very good recording of motor activity and sleep. And with a sleep agenda, the sleep agenda needs to be filled by the patient. I go to sleep at this hour and I wake up at this hour. This also is very helpful for us because for 7 days we know whether the patient has slept enough or not, whether the life has been normal or not, and we can have a very good picture of how the patients come to us in what state regarding sleep. Then they are recovered in hospital for 3 days. And as I showed you on the picture, their sleep will be recorded with electrodes, electroencephalograms of brain activity, but also breathing will be recorded, the heart rate will be recorded. And as far as the electroencephalogram is concerned, we have added electrodes. We have 21 electrodes in total, so that we can have a much more accurate picture when it comes to analyzing the recordings, and we can also see much better what will be done in the coming years. So initially, we perform a standard polysomnography. The patient is asleep, and during the second day, we do what we call tiles. Tiles are iterative, in French, iterative tests, which are 5 tests conducted during the day when the patient takes a nap. And during the nap, we can see whether the patients will really go to sleep or not. And this helps us assess somnolence during the day. And between the naps, there are cognitive tests being conducted, which I will describe later. And the third day, polysomnography will be repeated for a second night. And the third day, we do the reverse. The day vigilance tests. So it's the opposite of the tiles. We ask the patient to try and resist going to sleep. In the tile test, we ask them to go to sleep. Now we ask them not to go to sleep. And so it allows us to see the quality of sleep at night, and it also shows us whether the patients suffer from somnolence during the day, and we can characterize objectively the capacity to go to sleep and resist sleeping. On day number 3, we see the capacity to resist somnolence. These exams are conducted in the hospital, in the same ward where we treat other diseases. 21 electrodes are used so that we have a much accurate set of data, and we can analyze the electroencephalogram, and we can do a very accurate, fine-tuned analysis of the signals recorded, and it will tell us whether the brain structures which normally produce a number of signals have been altered. And then at the bottom of the slide, we see the questionnaires. There are questionnaires on all possible sleep disorders reported by the patients. There are questionnaires on the quality of sleep. There are questionnaires on insomnia, bad dreams, nightmares, agitation at night, depression, anxiety, because we know that mood is affected, and it has a huge impact on the quality of sleep. We also take blood samples. We collect urines to measure the quantity of melatonin in urines. We can assess the quantity of melatonin in urines. Melatonin is a hormone, and the secretion can be altered in Parkinson's disease. So we measure the quantity of melatonin in urines. We take blood samples, and we also analyze the gut microbiota in order to try and establish correlations with the sleep disorder. I'd like to tell you now about the cognitive tests that we perform between the naps. This test is the Sustained Attention and Reactivity Test, SART in English. This test attempts to assess concentration. The patient wears a kind of helmet with the electrodes, and there are figures appearing on the display. And when the number 7 appears on the display, the patient must push a button. And the instruction is when number 3 appears, the patient should not push the button. And so the figures keep coming up on the display for about 30 minutes. And every 5 minutes, the test will be interrupted, will be discontinued, and we ask the patient, are you focusing? Are you focused? If yes, what were you thinking about? If not, what is happening in your brain? Is there a blank moment? Are you simply drifting off and dreaming? or is your attention focusing on something specific? And how do you feel with regard to fatigue? Are you tired? And then we try to analyze whether any mistakes have been made between the numbers 3 and 7, because after quite a 30 minutes, patients will push the button at the wrong moment and not push the button when the number 7 comes up on the display. So we try to analyze whether that could be connected with local sleep-related abnormalities. For instance, a sleep appears during the day for a few minutes at a time when it's not supposed to be there. It's already been described in patients who have attention deficit disorders. They may go to sleep for a few minutes, so we try and understand that and see whether it might be combined with somnolence, because the patients have been taking naps between the tests. So we try to establish the link between these short somnolences and the attention deficit reported by the patients. So that's the picture for the protocol that has recently started. We hope that understanding better will help us treat better. Sleep is a very mysterious world, but we can actually try and understand this sleep with questionnaires providing lots of information. And we can also perform exams that will help us understand better what is really happening in sleep disorders. I'd like to introduce the other participants in the study. As I said, it's a multi-center study. We have the coordinating center in Paris. There is a PhD student, a project manager, some hospital doctors, researchers. I don't have a picture for everybody, unfortunately. One of them showed a picture of Lille, but not of herself. But here we have all the coordinating centers. Laure Peter-Direx in Lyon, Marie-Aline Lamontigny in Clermont-Ferrand, Patricia Avril in Nîmes, Lorraine Leclerc-Visonneau in Nantes, and Lise Lanvin in Lille. So those are the people who act as coordinators and work with us. In their own centers, they are the coordinating investigator. And we are going to conduct a study with them, and we hope that we will find some really interesting things. Thank you very much for your attention. Thank you. Thank you. Yes, we will keep the questions for the end, but we will be asking you some questions. If you have your phones available with the QR codes, we ask you two questions. One question and the other one is just one word. The first question, can we please have the first question? When do sleep disorders mostly appear during PD? Late, so B is during the first stages, A is late, and C is never. So please answer based on the presentation you just heard. We will give you a few seconds so that we have many answers. And right from the beginning, at the very early stages, the sleep disorders are already appearing, and we will see whether in some patients, maybe they only appear very late during the course of the disease. Now we're going to move on to another question. We're going to ask you to just say one word. So can we please have the second question? I don't know it by heart. Just one word. One word. What does a good night's sleep represent for you? If you sleep well, if you spend one night and you sleep really well, what would be the word that it makes you think of? So happiness, recovery, waking up in good shape, relaxation, resting, peace, quiet. Recovery seems to be the biggest word. Recovery, rest, peaceful, in good shape when I wake up. I don't know if you want to comment a few of those words. Like, not surprising, really. That's what we expected. And 8 hours non-stop sleep, recovery. Recovery really wins the battle, because the big word is the one that most people mentioned. So, okay, we'll keep those words in mind, and we're going to move on to the next speaker, the next presentation. The local speaker, Professor Pascal Kendarick, is going to talk about the gut.
Yes, I am local. So thank you very much for bringing me here. And I would like to thank many of the people who are here who were part of the research protocol, which was carried out locally. I'm going to be telling you about digestive tract in Parkinson's disease. It's quite trendy, and for the past 20 years or so, maybe a little bit too much, but we can talk about it. And if we're to talk about the digestive tract in Parkinson's disease, there are some important elements that I need to remind you of. In our digestive tract, we have a number of things. We have the enteric nervous center. It's not a nervous system, sorry. It's not the most important population in our gut, but it is essential, and we'll get back to it. We have some at every stage of the intestine, at the lower part of the esophagus, in the stomach, in the whole intestine, in the colon, and even in the rectum. There's a bit less, but we even have some there. So throughout the intestine, we have neurons, and it's a system which is a bit specific. It is closed in, if you will. It's an irregular system which is made up of little nodes, and I can show it to this. It looks a little bit like a very fine net, and it's an irregular system, and we'll get back to it. But it's an important nervous system for the well-being of the gut, and it enables the mobility of the digestive system. And if it doesn't work well, we're highly constipated. And it also regulates finer things such as the digestive secretion. It has to do with absorption and so on. I can go back on my slides. Good. So you can see the myenteric and submucous plexuses, and this enables us to produce stools, and the other one, which is closer to the lumen. And I have my figures, I always forget them. It's a bit like France's debt. We tend to forget about it. But a German team showed that in a human digestive tract, there are 168 million neurons meshed again. An important element, it's often said that this nervous system is autonomous, which is true. In a Petri dish, if you bring air and food, it's going to contract on its own for a while. But as you can imagine, it's autonomous, but a little bit controlled. Let's say it's a teenager. Not everything is done independently, and there are connections between the gut and the brain. And this is called the autonomous nervous system, which is a system we don't think about. I'm talking to you and digesting at the same time, but I'm not thinking about the need to digest and secrete and so on. We call this by different names, and there's a very important element, which is the vagal nerve, which goes between the base of the brain and the intestine, and it enables an exchange on a two-way exchange, if you will. It's like a highway. An important element about this enteric nervous system, and this is something a bit old now. As you know, the intestine is more easily accessible than the brain. You can take little pieces of intestine during a fibroscopy or a coloscopy, and you'll be well aware that from time to time you need to have a coloscopy, and the surgeon will take a biopsy. The biopsies are usually there to see whether there are cancerous or precancerous lesions. But what we've shown is that in the lab, if we stretch the lesions, get rid of the intestinal cell layer, which is specific for the gastroenterologist, most often you have access to neurons. The neurons I was telling you about, those who are inside the submucous plexus. You can imagine the system. It looks a bit like a fishing net. Sometimes there are no neurons, but sometimes there are some. And when we do get some, we can analyze them. So this is from the 2010. But we can not only see the neurons, which is shown here on this slide. In the square, in the box, you have 3 neurons, and you can see this network, this incomplete network, just on a biopsy. So this is not to show you a picture of my wife, even though she's the one who shot the videos and we're still married. She works at the lab and she made this video. I just wanted to show you, and I have to advertise for research, don't I? But it's a real challenge to be able to identify those neurons in digestive biopsies, because those are very tiny, they're very small. If I press here. Anyways, these digestive biopsies are very small. They're about 4 or 5 cubic millimeters, a grain of rice. Sometimes it's basmati rice, and sometimes smaller. But it's a real challenge to be able to analyze cells, which are not intestinal cells, but neurons, based on those biopsies. And this, as you can see, requires a lot of patience. You need to dissect them, stretch them, use pins, very fine pins on a box. All of this under a binocular device so that it works. Now, if I talked about being able to look at these neurons, you can imagine that the lab's work has shown that based on those biopsies, not in everybody, but we could find the same anomalies as in the central nervous system. Now, this is a central nervous system disease, a brain disease, and to say that we can find this disease, we need to be able to, when we look in the microscope, see little inclusions which are present in the neurons. Those are called Lewy bodies. And I've put pictures of my friends from Angers, specialized in neuropathology, and they've analyzed this under the microscope. And you can see that there's a little ball, which can be seen on some pictures. On other pictures, it looks like a little thread. Those are called Lewy bodies. If it's present, it means it's Parkinson's disease. It's not something similar. It is. Now, the techniques highlighting them are quite different. These are older pictures, but my colleague, who's a neurologist in Lille, took them. And in parallel, we can see the same pictures as the ones we can find in the brain. We can see this little red clump, which is present in the digestive tract, which is very similar to the one found in the brain. And we can see threads which are the same ones as the Lewy body we can find in the brain. In a large proportion of people, you can find the same lesions in the digestive tract as in the central nervous system. Hélène Pouclet at the lab, I think she's now called Mrs. Courtemanche. These pictures came from stomach biopsies, and you can see that we were able to identify the presence of the disease here. The previous biopsies were done on an entire intestine. This was due through biopsies. These enabled us to analyze the neurons present in the digestive tract and whether they were processed or dissected properly. We can find the same lesions. And this is an important element. So all of this of parallel damages in the brain and the intestine has, of course, raised quite a lot of interest. And since there's this communication between the brain and the gut, people thought, well, maybe the disease starts in the gut and then reaches the brain through this autonomous nervous system we were talking about. And some people thought, well, no, maybe the brain influences the gut and communication goes from top to bottom. And of course, other people thought that it could be a two-way communication. And there's yet another possibility, which is to say that all of this is independent. There's no communication between the two. Those two processes develop in parallel, and it doesn't have anything to do with communication. And I've put two pictures of two guys here. One is younger than the other. The one at the top is very well known because he's the one in 2006 to think that this could all start in the gut. And I put another picture of Per Bergamer, who does functional imagery, and he's worked a lot on this type of scenarios in order to find scenarios on both possibilities. Is it first the brain or is it first the gut? I'm doing this very quickly just to show you the latest data from the lab. If we look at what Pergamer and Brack suggest, that it would start in the gut, and we need to be aware of going too fast. But if the disease starts in the gut, the intestine of people suffering from Parkinson's disease should be too porous. We have a barrier in the gut. The cells of the gut are there to protect us. It's supposed to be a quite closed system and not too porous, because if it becomes too porous, it would just leak a lot of crap, if I may say so, through. And this could go to the neurons or elsewhere. Now, in the disease, if we start from the digestive origin, then the intestine would be too porous. And at the lab, we thought, well, since we can analyze the permeability through biopsies, we could analyze the permeability of the Parkinson's disease patients. As you can see, we can study this permeability, and I'll show you how we can do it, but we need to remember that this is a complex system which is easily summarized. All of these cells which are present, which line our gut, are present throughout the intestine. The neurons are right underneath, and they are held together through little molecular locks, if you will. If the locks are sturdy, the cells resist well, but if they're a bit loose, then more things can go through. And I'll get back to it, but some proteins are making up these locks. It's a quite clever system with proteins going through the membranes. And I'm not a good mechanic, but it's a bit like a little wall you would put, and there are little screws to hold everything together. So what we said in the lab is we're going to analyze people's biopsies, and if we want to analyze them, of course, we can look at the proteins making up this little lock system, but we can also analyze them functionally. I didn't put the video here, but this is very similar to what I showed you. It's a very tiny biopsy, a grain of rice. It is stretched and dissected and put in a little cassette, which is put in a chamber, and where there is a first chamber and a second, depending on what we want to look at. There's a fluorescent marker that we can monitor, and we can see how fast it goes through the biopsy. As you can imagine, the more porous the intestine, the faster it'll go through. The more resistant it is, the slower it will go through. So let me get back to this. You'll remember this was the same picture. Dr. Lorraine Leclerc-Visonneau, specialized in sleep, worked on this, and Thomas Clérambault worked in the lab. And when we analyzed the passing of those molecules, and we compared between Parkinson's patients and non-Parkinson's patients, we looked at the difference, and there wasn't any, which is a bit strange. And we thought, well, no, this does not support the digestive origin of the disease. But another element we need to remember is that there's not only the functional aspect, but maybe it's the little locks, even though it doesn't have a direct consequence on what we can see. Maybe those little locks have problems. Now, Thomas Clérambault, who was working with Lorraine at the time, was very good with microscopes, and he had found ways of taking a better look at biopsies, and he looked at them as if he were looking at them from the inside of the gut with a specific technique. And you see that they're like beehive structures in people who don't suffer from Parkinson's, and in the patients suffering from Parkinson's, we can see that it's a bit disorganized, as if these little locks were, even though they maybe still work, they're not as efficient, maybe. And we were a bit disappointed because we expected more digestive permeability in the patients and the PDs. We found morphological problems, but no functional problems. And this supports what Pauline was saying before. We know that this disease is highly progressive, and there can be specific sleep disorders appearing 5, 10, 15 years before the very first signs of the disease. So, early symptoms. And Lorraine is specialized in sleep, so we thought these people who have people with sleep disorders, in particular REM, sleep disorders, and we thought that we had to analyze people who had an early onset disease. So we looked at digestive biopsies for people who had an REM sleep disorder. And here you can see different measures. I just wanted to show one element here. If we look at people very early on with people suffering from REM sleep, we see no difference between these patients who already have clear Parkinson's, and people who don't suffer from Parkinson's at all. So what can we say? There's a lot to be said, but we can say that there are probably lesions which are almost identical between the digestive tract neurons and the brain neurons. This is something which has been proven. And there are advantages and drawbacks, but it's easier to carry out a gut biopsy than a brain biopsy. If we want to do research, it might be interesting. Now, this being said, there's still a question. Does this really play a role, has a function in the development of the disease? Is it a mirror of what's going on in the brain, which is great? Or can the gut trigger or enhance the development of the disease? We don't know. We still have to investigate this. And I'd like to thank France Parkinson, because you've been here for a long time, but beyond France Parkinson, I'd also like to thank the associations, the local associations who've been very dynamic. The Parkinson's Association from Vendée, from Loire, and without them we could never have launched this research. Especially in the digestive sector, for the past 15 years, we've been supported by patient associations, local and national, which has enabled us to develop more active research. And there's now a European network, thanks to what was initiated locally and nationally, to enable us to work within the network. We have a Slovak, an Italian, and a German partners to analyze the role of the digestive tract, and I will leave it at that. Thank you. Thank you very much for this presentation. We're going to move on to questions. Could we have the first question? And we'll see if you followed the presentation. What element links the intestine to the brain? The vagus nerve, the optical nerve, the sciatic nerve, or the facial nerve? 100% vagal nerve. So people have listened well. This also enables us to relax and move on to the next one. Optical nerve, we'll talk about it later. And then we can move on to the next question. If your intestine could talk, what would it say about Parkinson's disease? In one word. Turn around, move. Oh, darn. Digest. Beep. Buy. Jam. The objective here is to relax. Obviously, once one word appears, more ideas come. We'll let it go on for a few instants. When you're online, you can also participate, and then we'll be moving on to something totally different. There are a lot of questions about sleep and about the gut as well, which have come online. There are many words, and we're going to move to the last presentation with Sarah Meoni from Grenoble, and we're going to be talking about feminine side of Parkinson's. Hello to everyone. Thank you for being here. Thank you to France Parkinson for this invitation. And together we're going to tackle a totally different topic from what we've heard so far. We're going to be talking about the Lady PD study, which was specifically developed in order to study the fluctuations, hormonal fluctuations in Lady PD patients. We know that each patient is different, but there are also differences between men and women. We know that this disease is more frequent in men, and there are also clinical differences. We know, for instance, that women have a tremor component, which is more developed than for men. They suffer more from dyskinesia and so on. So there are important differences between men and women, and we need to keep those in mind when we're talking about clinical studies in order to adapt the care and treatment. This is called precision medicine, in order to finally target the care of a given patient, taking into account the differences between men and women. Now, the main promoter and the main investigator was Professor Elena Moro from Grenoble. And through this study, we're able to enable women to better identify and manage hormonal factors which can trigger the disease, or the symptoms rather. Why did we think about this? Well, because there are interesting differences, and we've seen that a certain percentage of women show an increase in the symptoms during the week before and during their period, with an improvement after their usual symptoms come back. Now, this topic is not well known, a bit underestimated, but it's important because it has an impact for these women professionally, personally, in their everyday lives. And it's also important because 20% of women suffering from Parkinson's disease are less than 60 years old, so potentially impacted by this increase in symptoms during their period. Right now, we lack data on the effect of hormonal fluctuations and its effect on women's everyday lives. We don't have official recommendations regarding how to adjust the treatments either. And that's why we decided to carry out this study.
The idea is that the menstruation interfere with the motor and non-motor symptoms in PD. This is a multicentric study. 4 centers are participating in the research. There is Toulouse, Nantes, Rennes, Grenoble. And we are going to enroll 100 female subjects suffering from Parkinson's disease. The trial is a pilot trial, which means it's the first time that a trial is looking into this specific subject, and it could open the way for more studies in the future. The main goal is what we're really looking for is to document changes in Parkinson's disease symptoms during the menstrual cycle, thanks to a digital application called My Moves Matter, and what's specifically developed for the trial by a woman who suffers from Parkinson's disease. And she collaborated with the France Parkinson Association, so she's really obviously familiar with the matter. And we're going to look into the changes that happen with this application. But there are other endpoints, secondary endpoints in the study. We compare the collected motor data that we collected with the mobile application to obtain some objective data collected during the clinical examination, the neurological examination. And we also collect data thanks to with the help of a device called PD Monitor. It's a connected watch which can be worn by the patient, and it collects data regarding abnormal involuntary movements, dyskinesia, and other such data, and it provides a collection of motor data that can be compared with the other information. Finally, we determine whether a change in the treatment introduced by the neurologist is or is not efficient. Once we have all the data in the application, we value whether the change in therapy has any benefits. We can also assess whether there are differences between women, depending on whether they are on any birth control therapy, whether this makes a difference regarding motor symptoms. We want to understand also whether the digital application is easy to use, very user-friendly and convenient or not. So who can participate in the trial? We're looking at women between the ages of 18 and 56 who should not be menopausal and diagnosed with Parkinson's disease according to the official criteria, and who have been suffering from the disease for at least 2 years before they are enrolled in the study. And these subjects should be on a stable medication for at least 2 months, and for whom we do not plan to change the medication for the next 3 months. The subject can also be on birth control therapy, such as pill, birth control pill, or an intrauterine device. There are some contraindications, criteria for non-inclusion, for instance, women who are in the perimenopausal period, or any condition which, according to the investigator, could prevent the study from being successful, prevent the subject from participating in the study appropriately, such as advanced cognitive disorders or severe depression, or people who are incapable of using the digital application for many reasons, for any reason. Practically speaking, what do? We start by enrolling the patients in all 4 centers. All 4 centers are specialized centers for Parkinson's disease. The patients are seen in day hospital or during hospitalization by the neurologist, who may ask them whether they want to participate in the study. Then there will be a specific appointment with an interview. We check all the inclusion criteria. We also perform a neurologic examination with a motor scale and other questionnaires regarding quality of life. And we also put the app in the patient's smartphone and explain to the patient how to record the data and enter the data in the smartphone application. The patient will go home with the application, knowing how to enter the data regarding motor symptoms and also the menstrual cycle during the whole duration of the study. And the study is meant to last for 6 months. After 3 months, there will be a video appointment with the patient just to check that the patient has been able to use the application appropriately and that all the data has been recorded, and we directly have access to the data collected by the application. The neurologist can see the data and possibly adapt the therapy depending on the motor fluctuations entered by the patient. Say, for instance, the patient found that 4 days before the menstrual period, the motor symptoms worsened. Then in that case, the doctor can suggest to increase the treatment in the days before the menstrual period. And this is the appointment at the end of the study. Very simple: clinical assessments, motor scale, questionnaires on quality of life. And also we perform a few scale interviews regarding whether the application was easy to use and whether the patient feels that it worked well. Now, this new application can be used on Apple and Android smartphones, basically on all smartphones. There are several thumbnails, and with those thumbnails, the patient can enter motor and non-motor symptoms. The patient can enter the type of symptom, but also the severity of the symptoms. And we can also follow the menstrual status on the day of the menstruation, the duration of the menstruation, whether there is a change in the symptoms before and during the menstruation. The patient can also write in the agenda a detailed account of all the symptoms that she may have observed, so that we have additional information and more accurate information. There's also a specific thumbnail for therapy, medication. And depending on how and when she was taking her medication, what fluctuations were observed regarding the motor symptoms. Finally, there is a small subgroup of female patients, female subjects, 10 patients, in whom we observed changes in the symptoms during menstruation and who were included by the Grenoble Center, and they received the PD monitor. The PD monitor is a connected monitoring device which has already been tested, and we want to perform a sort of sub-trial, a subgroup trial with the PD monitor, so that we have even more accurate motor data to be combined with the other data collected. This is the team in Grenoble who has been working on this trial. And I would also like to thank all my colleagues from the other centers, Nantes, Rennes, and Toulouse, who participated actively in the trial. All the centers have already started enrolling patients. We started early this year in 2025. We need you. We need your support if you would like to participate in the clinical trial, because without you, we're not going anywhere. Thank you very much for your attention.
Merci beaucoup.
Thank you. Before we move to the Q&A session with the audience and the people who are following us online, we're going to do the last poll. So question, please. Did you listen? What digital tool is used in the Lady PD study? My Moves Matter, Parkinson Go, Parkinson app, and Move My Body.
Move My Body.
Again, apparently everybody has been listening, and you may download the application if you're interested. You can also talk about the development of the application if anyone is interested in the audience. Now, the next question is more a yes and no question. We'll see whether yes or no prevails. Did you know before you came here today that hormonal fluctuations could influence Parkinson's disease symptoms? And that's why these studies are so important, because they make us realize that women are not sufficiently taken in consideration in the studies. In the dosing regimen, for instance, women are not men, so the dosing regimen should be to take in consideration the fact that a woman is a female patient. So no prevails. So My Moves Matter. That's the name of the app, and women are not men. Okay, let's move on to the Q&A session. We have two colleagues with roaming microphones, and they will be circulating in the room. Please wait for the microphone to ask a question. We will take one question per person. We cannot allow you to ask too many questions, unfortunately. And please, no personal questions. We have three neurologists here, but we're not in a neurology medical consultation. So please don't ask any personal questions, but rather ask questions about the presentations that were made today. So raise your hand if you want to ask a question, and you will be given a microphone. We also have questions online, so we need to ask both types of questions. This question from an online viewer is how to select the patients for the studies, and what should we do to participate in one of the two studies, the sleep disorder study and the Lady PD study. So if anyone wants to participate, what should they do? Should they live in one of the cities where the centers are, or if they live away from one of those centers, can they maybe travel to the center? Maybe you can both answer the question. What the easiest thing to do would be to contact the center closest to where you live. Obviously, it's better if it's your neurologist, your attending neurologist, who sends you to refers you to one of those centers. In Paris, we have collaborations with other neurologists in other hospitals. They will refer the patients to us. So everything should go through the neurologist. But as a patient, you may ask your neurologist to refer you to one of those centers. And it's more useful for us to go through the neurologist, because we can then obtain detailed information regarding the patient. We sometimes need to find out more about the patient, things that only the neurologist will know. So we need the help of the professional. In the SEMPARC study, there are no inclusion criteria. So you have to be registered with the Sécurité Sociale health insurance. But depending on the stage of your disease, you have to spend 3 days in the hospital wearing lots of sensors. So you have to be okay with that. It's not very funny. It's not painful, but it's not very nice, because you can't really move around so easily when you're covered in sensors. The same for the Lady PD study? Well, yes. We enroll patients who already are being treated in one of our centers, But we collaborate with a number of neurologists. There are community neurologists who will select the patients and refer to us those patients who are interested and willing to participate. Well, I'd like to advertise France Parkinson. On our website, there is a dedicated page for clinical trials that are recruiting, enrolling patients in France. There's also a poster just outside. I mean, nothing new here. We're simply using the information from the other clinical trials, and there are contact names, people you need to contact. If you want to participate in a clinical trial, you should talk to your neurologist. And there are inclusion and exclusion criteria. So the neurologist, the hospital or community neurologist will need to check whether you match the inclusion criteria. They don't want to give you false hopes either. And the neurologist may contact the center and check what can be done. You don't need to live in Nantes, Paris, or Grenoble. But in that case, if you need to travel to one of the centers, your travel expenses will be covered. I mean, we have that in the budget already. If you live in Marseille, you don't want to go to the Grenoble center, obviously. And if you live in a place that has a train station that will take you to the center, it's possible. Is there a question from the audience? Yes, I have a question for Professor de Kinderen. Professor, have any trials been conducted regarding the relationship between the microbiota and the gut in Parkinson's disease? Yes, of course, your question is relevant. Several studies have been conducted, again, based on the idea that the gut microbiota is in close contact with the gut cells and not very far from the gut neurons. And so there may be an influence. But mostly, in most studies, if we analyze the bacteria, the gut bacteria, we find that they are different between the people who suffer from Parkinson's disease versus somebody who doesn't suffer from the disease. And most of the studies have provided positive results. I can't remember really, but I think there are something like 25 or 30 studies available. And the microbiota issue is a bit complex. Depends on where you live and your eating habits. In China, obviously, they eat different things, so they have different microbiota. But bear in mind that some results have provided negative results, and either they have not been published or they have been published in a much more confidential way. Many subjects need to be analyzed. So to keep this short, one might think, okay, if we analyze the GI bacteria that are present in the stool and we have a marker of the disease. No, it doesn't work that way. Unfortunately, there is too much overlapping. There is not enough difference so that it could be used as a marker. So yes, there may be differences. They're not always the same, so it's not always reproducible. And again, we always talk about the positive studies and less about the negative studies. There are differences, and they may play a role in the disease modulation, but they can't be used as a marker, as something that you do every day. You give the lab a stool sample, and they tell you whether you have the disease or not, the same way that you would do it with a blood sample. Unfortunately, we can't do it so far. Well, you just answered a question that was asked online. Could this be a diagnostic tool better than MRI? Well, no, I mean, MRI, some people tried. We had a collaboration with a company, with Alexandra Chervino from Luxia Scientific. They tried to do it. They said, okay, it's going to be relatively expensive, but could it be a marker? And it didn't work out that way. There's too much overlapping. If we take somebody at random, we can't say, oh, you have Parkinson's disease with an 80 or 90% accuracy. Maybe with more refined examinations, it would be possible, but that means it's more complex. You need more complex equipment to find a marker. It doesn't work that way yet. Okay, I'll move back to
Je vais
a
être assez
question
question en
that
ligne,
has been
si on va
asked
tourner
online,
vers le
back to
sommeil.
sleep disorders. The
Euh,
question is, what
et
is the
la question
percentage
qu'on
of
nous pose,
people
c'est quel est
who
le pourcentage de personnes qui
simultaneously
présentent
have
simultanément
all
les
the
différents troubles du
sleep
sommeil?
disorders, insomnia, RPD, etc.?
C'est une question pointue.
Oui, c'est surtout que
I can't
alors,
remember exactly,
je
but
n'ai
I think
plus
we
en
did
tête,
that.
mais on l'avait
We
fait
we
sur
looked into
une
that
étude
in the iceberg study. It was
iceberg,
a
un
Lapitié-Salpêtrière
cohort
cohort of patients,
salpêtrière,
and we looked at
justement
the 5 sleep
c'est un des
disorders:
troubles du sommeil, que ça
insomnia,
soit
somnolence,
voilà, l'insomnie, la somnolence, le
RBD,
trouble du
restless
sommeil,
legs, and
paradoxal
sleep
du
apnea.
repos et l'apnée du
But
sommeil. Donc,
unfortunately, off the
je vais
cuff, I
peut-être
can't
comme
remember.
ça, difficile de dire, mais
What I
ce que
can
je
tell
peux
you
dire,
is that
c'est quand même
if
qu'en
we talk
co-occurrence,
about
c'était
co-occurrence,
très fréquent.
very often patients
Ceux
had
qui avaient au
two
moins
of
un des
those
troubles
sleep
du sommeil, mais
disorders,
qui n'avaient pas
but there was
vraiment
no
une dominance
preferential co-occurrence.
privilégiée.
Insomnia was not necessarily
L'insomnie,
more
actuellement, c'est pas
associated
plus
with somnolence
associé que
than
l'insomnie,
RBD.
le trouble du comportement sommeil paradoxal.
The only
La seule chose qui était un peu
association we
associée,
found was
c'était l'insomnie d'endormissement, donc les
difficulties
difficultés à
going to
s'endormir,
sleep
avec
with the
le syndrome des
restless
jambes sans repos.
leg syndrome,
C'était
which
complètement attendu.
can be
Un
expected.
syndrome des jambes sans repos
It's
classique
normal.
et
When you
commun
have
avec
restless legs, you
plein
have trouble going to sleep.
problèmes
So that was the
d'endormissement.
one
Donc c'était
correlation
assez
that was
attendu.
to be
Voilà.
expected.
Donc la
But the
co-occurrence, en fait,
co-occurrence is
elle est assez
frequent,
fréquente, mais
but
elle n'est
there is
pas
no specific
pas une
order
co-occurrence
which
spécifique.
symptoms goes with which
Voilà.
symptoms.
Donc
So
il ne faut pas
you shouldn't
s'arrêter
worry if you have one
sur
disorder, doesn't
forcément
mean
avoir
you're going
tous
to
les
have
troubles.
another
Non,
disorder.
non, non, ça va pas
C'est
donner.
souvent
Que
aussi
people worry.
les
They
gens
think, okay, if I have
s'inquiètent
this
pour ça.
disorder, I'm going to have another one. There was a question from the
On avait une
audience at the
question dans
back
la
of the room.
salle au fond.
Yes, question for
C'était
Dr.
pour
Daudet.
Dr
You
Daudet.
said there was not necessarily a
Il y avait
correlation
une
between
corrélation entre la
day
somnolence
somnolence
la journée
and
et la mauvaise nuit
sleepiness
la
and
nuit.
sleepless
Mais
nights.
est-ce que
But is there a
il y a une
correlation
corrélation
with the
avec prendre des
fact that
médicaments
people
la
take
journée
drugs during the
alors
day
que
and they
la
have
somnolence,
Oui, bien
ça va
sûr.
faire
they
couper
suffer from sleepiness, somnolence.
En fait, la somnolence,
They
elle est
fall
assez
asleep during the day.
complexe.
Well, that
Enfin, elle est d'origine
issue is
multifactorielle.
multifactorial. There are
Ça ne veut pas
several
dire absolument que,
reasons.
enfin, forcément, si
If
on
you
a
don't
une
sleep
mauvaise
well
qualité,
at
ça peut,
night,
ça
it
peut mener
may
à un lien
lead to you being
d'assouplance.
sleepy during the
C'est vrai
day.
que, enfin, probablement que
But the
la
biggest
part la plus importante, c'est quand
share
même,
is
enfin, le
the
traitement.
medication.
C'est aussi pour ça
And
que
that's why
parfois,
it
il faut
changes in time
dispenser.
when the therapy
Il y a
changes.
aussi besoin
And
d'atteindre des centres
there is also the vigilance
médicaments
centers that
c'est
can be
pour ça.
involved in the
Et puis
disease.
après,
And
ça
so
dépend
that
un peu
leads
des
to
profils
sleepiness.
des patients. Il y a des
I had
patients,
patients
moi j'ai eu
who
des patients avec
had sleep
médicaments qui faisaient
apnea
du
and
sommeil
did
absolument
not
de
sleep
mauvaise
well
qualité,
because they
parce
had
que
motor symptoms during the night.
symptômes
They could
moteurs,
not
mobiles,
recover
qui
well
étaient
during
complètement
the night
déréglés
and
avec
they
plein de
fell asleep
dysfonctionnements.
during the day.
Quand on
And when we
improvait aussi
improved the
petit à
motor
petit ces
symptoms,
symptômes
their
moteurs,
sleepiness or
souvent ça
somnolence
revenait
during the day
rapidement.
was improved.
Donc, voilà, c'est jamais une vérité absolue
So
de dire que, voilà. Mais
we
voilà,
tried
parfois on s'évertue à essayer de dormir
improve
absolument plus longtemps
sleepiness,
que la journée.
sleep
Et
quality
parfois, en
during the
fait, on
night
y arrive un peu après. C'est
and
vrai qu'il y a
to
beaucoup
improve
d'études récentes qui
sleepiness
montrent
during the
aussi
day,
que
but
la
it's not that
somnolence,
simple. Especially
notamment les
dopaminergic
agonistateurs,
agonists play an essential role.
On va
We
retourner
will go back to
sur le féminin.
Lady
Il y a une questionnaire qui
PD.
nous demande
If there is
s'il y a une
symptom
corrélation
hormone correlation,
hormone-symptôme, est-ce qu'un
would
traitement
a
hormonal
hormonal
pourrait
treatment
fluctuer le
be a
traitement
possible
symptomatique
complementary therapy to
complémentaire de
Parkinson's
la maladie de
disease?
Parkinson?
Alors,
It's a very
bon,
relevant question.
c'est un peu
Thank you.
pertinente en
Ah non,
fait.
mais
Ouais, ouais.
We
Alors,
are
déjà, on est encore
at the preliminary
en stade
stages.
préliminaire, donc on cible
Obviously,
déjà, on
we're
a
trying
bien
to document
documenté
this
et pouvoir
well and
analyser
analyze
l'adaptation
motor
des
fluctuations
TCT,
and
voir
see
déjà si
whether
l'adaptation du traitement
dopaminergic therapy
dopaminergique,
can be adapted,
donc
the
qui va
anti-Parkinson
fonctionner
therapy can
avoir
be
efficacité.
efficient. But
Après,
also, we can
on
think
va
about
réfléchir
hormonal
sous le
treatment.
traitement hormonal,
But
mais
again, this is
ça va
going to
être,
be
à mon
fairly
avis, un peu
complicated
compliqué vu
because
qu'il y
there
a
are
des effets secondaires
secondary
liés à l'adaptation. Donc,
adverse
il faut voir
events,
le traitement
and
hormonal
it's sometimes
sur
difficult. It has
sur la
impacts
santé
on
générale.
general health.
Donc,
So
aujourd'hui,
it's
c'est
a bit
encore un
too
peu trop
early
précoce pour, on va dire,
to for us to
réfléchir à
think
ça.
about that.
Mais
We
enfin,
will
on va
start by
d'abord
checking
si
whether by
l'adaptation de
adjusting
façon
the
dopaminergique
dopaminergic
peut
therapy, we can improve the
améliorer les symptômes.
symptoms.
Bon, je vais
Maybe the
rester
next
encore avec
question
vous
will
sur
be
les
for
cycles de
you as
symptômes,
well.
sur le même sujet. On demande
Can
si la
menopause
ménopause
play
en
a
soi
role
pourrait jouer un rôle
in Parkinson's
dans la maladie de
disease? Can
Parkinson.
it
Est-ce que
be a
ça peut être un
triggering
déclencheur
factor,
de maladie de
triggering
Parkinson?
Parkinson's disease?
Alors, il y a eu
There have been a
quelques
few studies.
études sur ça.
It's
En
not
fait,
very clear. There are contradictory data. Some studies showed that during menopause, with all the hormonal changes, the Parkinson disease frequency could increase, but other studies could not find an increase in the prevalence of Parkinson's disease in postmenopausal women. So we still need a large epidemiological study, and we don't have that kind of large population study. Okay, thank you. We will go back to a question from the audience. Professor Der Kinderen, could stress be responsible for an inflammatory state that could prevent the neurons from folding appropriately? Because I don't really see the connection between the brain and the gut. The brain cleans itself and the gut doesn't. So could there be a connection there? That is a difficult question. Your question is very relevant, but it's difficult. Regarding the role played by stress in the disease, it's very difficult. It may play a role, and you're right. Having a general state of inflammation, well, digestive, but also elsewhere, a general inflammatory disease, meaning you have a certain inflammatory state, that is not good. And that is definitely a risk factor. People have a tendency to develop the disease if they have a general state of inflammation. However, for the next part of your question, I don't really know, because stress is so variable, so difficult to quantify in man. To my knowledge, there are no well-conducted studies that will help us quantify that. The only data we have is interesting, but to be taken with a pinch of salt, because they are coming from animal models. It's easy to stress a mouse. Some mice may have Parkinson symptoms when they're stressed, and we can stress them in a rather reproducible way. It's easier to do, it's more easily done in animals than in man, because in man there are other factors. But there is a limitation in all the animal models. It's very difficult because this is a human disease, and therefore animal models are artificial. Mice, again, do not develop a real Parkinson's disease. They only develop the symptoms. So we think that, yes, there may be a connection. But, I think it's difficult to demonstrate, at least in a very formal way in man. One question from the back of the room. Can CBD do something for Parkinson's disease? Because people start talking about the effect CBD could have on Parkinson's disease. It's not the subject for today, but it's interesting. Cannabis and Parkinson, people have been discussing it for quite some time. It was very fashionable 4 or 5 years ago. It was very fashionable. Now, there are ups and downs. I mean, in the years 2000, 25 years ago, we have cannabis receptors in our brain. And possibly there is a connection between CBD, THC, and possibly there is an effect with the molecules we release, endocannabinoids. And apparently, cannabis receptors were very close to dopamine receptors. And there are many. There are 7 times more cannabis receptors than dopamine receptors. And so we don't know really what they're useful for, but they're very close. And they act on similar molecular targets. So we thought that might be interesting. And we found that cannabis could be a modulator of cannabinoid receptors, a modulator of dopamine receptors, that they acted as partners. And it triggered quite a few studies on what it could do to take tetrahydrocannabinol or more pure derivatives on Parkinson's disease. But the studies were rather disappointing. It didn't do better than placebo at the time. But for CBD, yes, it does this. It acts the same way. So there's a rationale. There's a biological rationale. It doesn't. It makes sense. It's not stupid to think it could do something. But right now, the kind of evidence we expected in a placebo-controlled study, we didn't achieve that. But there is a rationale. We think maybe there is something there. And if we look at the story of cannabis, hemp in diseases, 25 years ago, we swept it under the carpet because the studies did not.
Thank you. We're going to be going back to sleep. Have there been studies on REM improvement? Yes, absolutely. With deep stimulation, it improves the quality of sleep, the total amount of deep sleep, and it's been proven to be positive on sleep, thanks to the mechanism that insomnia and Parkinson's disease, as I was saying, depending on the stage of the disease, whether it's at the beginning or the middle, the causes evolve, and when there are fluctuations, when you're off, blockage happens more often. It can happen at night, and it's very uncomfortable. The patient wakes up because their sleep is of bad quality. They're stuck. They can't move in their bed. They're in pain, and so on. So treating them for motor symptoms throughout the night improves the whole picture. And so this can come into play. Yes, what about the subcutaneous pumps? Some people use it only at night. Yes, there was a study, apomorphy, launched by Flamand and Cochin, and we tested apomorphine only at night, and the patients felt that their sleep had improved. And initially, they suffered from insomnia and motor fluctuations, and they saw their sleep improving. So I'll get back to online questions, and then we'll get back to the room. I have a question dealing with what do you expect with a better knowledge of sleep disorders? Are the existing drugs not good enough? Yes, well, we do have lots of resources, but we still don't quite fully understand. It's like successive layers, one on top of the other. And it's interesting to get a broader view of things because most studies focus on one specific symptom, and there was no study exploring the causes of insomnia, because there are multiple causes, as well as the causes of drowsiness. So it's interesting to maybe take a look at what part each element plays, each cause plays, and then there are all the markers of sleep, which illustrates the way the brain works. We know that sleep has a regulatory effect, that it helps eliminate toxins, and so on. So are those markers already altered? And analyzing the links with the clinical condition might answer a number of questions we have. There was a question in the room for Professor Der Kinderen. Could you tell us about the state of research on glial cells, please? Yes. Again, this is trendy, but a difficult analysis. Of course, we could talk about glial cells in the gut, and I haven't talked about it voluntarily, but these cells are support cells. The better known are astrocytes in the gut, in the brain, and we have the equivalent in the gut. Just like in the brain, there are many more of them than there are neurons. There might be 8 glial cells for one neuron, and they probably play a very important role. They're not only there for support, but they have an energetic side to them and neurotransmitter role as well. Now, for the gut, there have been some studies of the enteric glial cells. They're difficult to study because of their very specific morphology. It's difficult for us to count them. If we just want a cross-section and identify whether there are many or not many of them, it's very difficult because their morphology is very specific. But it would be interesting to analyze them and to see, take a look at the ones in the brain. This is a very interesting topic, but even outside of the disease, it's highly complex, but it's a very relevant question. It could be an interesting marker, but once again, it's a very small world, and these cells are not ideal for a biological study. And I suggest you go and look at the poster of a young researcher about glial cells out there. There's a question at the back and then one question in front. Last year, France Parkinson had organized a conference on nutrition. This year, we're learning that our microbiota is similar to that of a person not suffering from the disease. Is it wrong to conclude that we should maybe look for a better diet, more balance, without expecting any effect on the disease? That's an excellent question. There's also always this link between nutrition, microbiota, and health, and so on. As you were saying, there are slight differences, and some strategies can be offered in order to play on these small differences between Parkinson's patients and those who don't suffer from the disease. Some things are being offered, but for now, we are not familiar enough with all of these bacteria. There's their makeup, but their function, and what metabolics they might secrete. Maybe in the future, when we are familiar with the metabolism of all these bacteria, we'll be able to give finer advice regarding nutrition. But for now, something is true for any type of pathology. Having something a quite diverse diet with, but there's no scientific basis to say you have this type of microbiota, you need to take this or eat that, and so on, in order to improve your microbiota. For now, we're not there. But when we've achieved a finer analysis and we can go beyond the makeup and look at the function and metabolism, maybe we could be more precise, more accurate. But for now, we can't do it, and you can't really differentiate. Yes, as you're saying, though, it's better for everyone to eat healthier food, less processed foods, and that's true for everyone. These are virtuous circles that we're trying to implement, but we do have another question at the back of the room. Yes, about the same topic, nutrition. You were saying before that when there's an inflammation, it doesn't improve the symptoms of the disease. So, do you promote anti-inflammatory diets, excluding gluten and dairy products, so as to reduce inflammation and the issues it leads to? Well, actually, no, and I haven't talked about it. For some people suffering from the disease, there's a bit of digestive inflammation, and I didn't include it due to time constraints. What we can do in order to measure digestive inflammation is based on the biopsies. We can analyze certain molecules which are important for inflammation called cytokines. And the same thing is true here. For some people, it'll be slightly high. If we analyze 50 to 60 people suffering from the disease, it's a bit higher than for non-patients. And in some studies, we found differences, and we need to be very honest. In some, we found no difference overall. So, but for digestive inflammation, it may play a role. And for broccoli, for example, which is anti-inflammatory, it was tested with the disease, and it doesn't change things much, really. So, other than in the case people have very specific indications, when we see people in consultation, they say, oh, I've adopted an anti-inflammatory diet. There's no contraindication, but we have no definite scientific evidence to support it either. And we have no way of measuring it either. I'll briefly give you an example, which is fecal transplants. The Finnish tried, there's a specialist there who works really well, and then he doesn't have any inflammation markers in order to assess the changes, if any. This is a highly complex topic, and we have a question. Can we ask for a biopsy apart from the case where the patient's prescribed a coloscopy? Well, when a coloscopy is performed by a gastroenterologist, it is put in paraffin blocks, and then you cannot analyze the neurons correctly for historical reasons. We participated in a number of studies showing that we cannot analyze the presence of neurons and pathologies unless the biopsies are desiccated, as I showed you. If and that can only be done in a gastroenterology lab. You can't ask for an additional biopsy. You could. There's no point in asking for an additional one. Another question for Professor Kinderen. Are there any studies dealing with the vitamin B overdosed? Maybe B1. No, I don't think so, but I don't know. There may be. People often talk about it during consultation. There are clinical cases, but maybe I don't know enough. I don't think there's a classic study where we've compared populations who've been supplemented with vitamin B1 and compared with placebo. No, there have only been open studies. It's an Italian doctor during his studies, and he died from COVID, and he treated many patients with vitamin B1, but there's no classic studies against placebo. There are things with a combination B1, B12 as well, but not in traditional placebo studies. Let's move away from the gut a bit. Could migraine be linked to Parkinson's? These are very specific questions. According to me, from what I know, there hasn't been any study analyzing the link between migraines and Parkinson's. So I don't think there's a direct link. And that's one of the most frequent symptoms during periods. It would be interesting to carry out a study within the framework of our study of hormonal fluctuations. But from what I know, we don't have any data about this. Another question said, could Lady PD lead to other research studies? Yes, this is a pilot study to describe the fluctuations during periods, and if we can confirm this, one of the secondary objectives is to see whether there are differences in symptoms between women under the contraceptive pill and others, or IUDs. This will give us indications in order to set up other studies. As we were saying before, under the influence of hormonal treatments. But Lady PD is a study which needs to be carried out at a larger scale in order to consolidate the data, and then we can target other symptoms or other treatments. Yes, listening to you, we understand why research doesn't move fast enough, because you need to take the time, because you need to confirm the results and check and so on. It's true that there are no new solutions being offered right now, and this is the objective, but there's a lot being done on Parkinson's disease, and knowledge increases, which leads to a possibility of improving treatments. and this is coming, but you carry out a survey or a study on 100 people, but then you need to confirm the results and expand it and so on, and it takes time. Yes, clinical studies take time in order to achieve sturdy data and to control the safety issues or aspects of what we're offering you. So we're working for you. It takes time, but we're moving ahead. And it takes time to make sure that what's going to be offered is safe. So we're going to move on to non-drug treatments. And what about meditation or self-induced trance in order to improve sleep? But I'm just reading what's written here. Meditation, maybe? Yes, well, meditation is very good for everyone. For sleep, and especially efficient on ruminations and anxiety, because you can then train to let go of your thoughts in order to relax and be able to finally fall asleep. I think it's interesting. It's an additional tool. What about self-hypnosis? Yes, it's not exactly the same thing, but all of this is part, or has the same objective in order to stop ruminating and the flow of thoughts, preventing sleep. Don't hesitate in the room if you have questions. Thank you very much. There's many of us here today, which means there are many patients. We know the progression year after year. Can we measure the evolution curve given the number of baby boomers who are more prone to this disease? And a more general question, you just referred to research. How is France doing for research? Do we have enough resources? And are there other countries in the world which are at the forefront of research for Parkinson's disease? Well, I didn't say that we weren't carrying out enough research. I think we're doing a lot. Resources, obviously, we always need more resources, but carrying out clinical research also means recruiting people, which isn't always easy. It's people dedicating time to research. Cutting edge countries, I think that France carries out a lot of very good research. But I'll hand the floor to the neurologist. Well, I tend to agree with you. And if you look at the research activity and you look at France, it's very dynamic. There are many teams who are really high quality. Of course, there are centers in the US which are maybe more targeted and so on. In Canada, in the UK. So you see, things have changed for the past few years, and I'm an old guy now. I've seen things developing. About 20 years ago, it was very difficult to launch something and to start. And things are always the same. There's national or European level funding. And of course, if we apply for this funding, there's almost no chance to get it. But right now, there's a diversity of opportunities, and it's linked to local and more specific associations. So if there's an emerging project being launched by somebody younger, not well known, I think it's easier to apply and achieve funding because we now have specific funding for Parkinson's. And some funding is now provided through France Parkinson. There are many possibilities now. So honestly, it's not too bad. And of course, it's not just the funding, but it's also the ideas, the underlying ideas. So not everything is perfect, but it's doable. And I think that there are, even in France, many teams who are you've heard about sleep. In Bordeaux, they're good at molecular levels. There are teams at the CEA, at Salpêtrière. They also work at the molecular levels. In Lyon. So for Parkinson's, it's not bad. It's always very difficult to compare, but we're not ridiculous, even though nothing's ever perfect. But I think that we can, and the association network, which goes beyond the national and European funding, offers us many possibilities, which are quite interesting. I'd like to add something regarding funding. In France, we're very lucky to have this network of Parkinson expert centers. So you never live very far from a Parkinson expert center. We've seen it today. We've presented research projects where there are several centers cooperating. So at the French level, there's a real wish to cooperate, and the clinical trials have proven it, and they cooperate at the international level as well. In the past, they all wanted to work in silos so as to get the funding and keep it, and I think that mentalities have evolved. We now have international consortiums combining different expertise. We have physicists and chemists who are going to work with clinicians in order to get as much data as possible. And when I used to do research, people used to work for themselves, but now it's either prerequisite or highly recommended. So things have really changed. And I'd like to add something. We increasingly ask for the opinion of the patients in order to develop a clinical protocol. It's not just the researchers or the clinicians, the physicians who are going to decide. Right from the start, we ask the opinion of the patients to see whether what they're thinking about doing is feasible, will be adopted, is it feasible, and is it worth doing? And this is something quite new. We're very proud because we're very involved with this. And now that we've started, we've had an increasing number of requests. And it's very interesting because it increases the possibility of success. And then regarding the curve, I will give the floor back to you. I'm going to launch the debate because because there's no formal response, and I have no knowledge of statistics. Some people are very pessimistic. There's a Dutch man who specializes in the disease, and he sees curves, very negative curves, and other people are a lot more cautious. I don't know where we're at. Well,
C'est toujours difficile,
it's quite
hein.
difficult.
Enfin, nous,
Our
on a quand même une courbe de
progression
progression
curve
plutôt
is
pessimiste
still
aussi
quite
avec quand on parle avec
pessimistic.
Alexis Elbas.
Yeah, it's working. If I can add something, it's that the population is aging, so the progression is just like other neurodegenerative diseases such as Alzheimer's, is also going to increase, and that's linked to the general aging of the population. But there are also the environmental factors such as pesticides, plastics. We don't know what influence that might have, but the forecasts are not very optimistic.
Et je pense que c'est une vraie.
And I think it's a real.
Le mot ne vient pas.
The EU has launched major funding in order to assess the impact of environmental factors on neurodegenerative diseases, but not only. There have been many calls for tenders in order to analyze the effects of PFAS or fine particles and so on. So a lot is being done in order to work on prevention. So this is also very trendy. We're getting to the end of our session. Last question. I have a question. I'd like to know whether Grenoble could become an expert center for pregnant women, for example, diagnosed with Parkinson's, who are often a bit lost, don't necessarily have an answer from their neurologist regarding how to adapt the treatment, what evolution there might be. That's a difficult question. Well, actually, right now, we don't intend to become an expert center for women suffering from Parkinson's disease, but we never know. It could be a potential evolution or a future project. Now, that's a very small percentage of PD patients. But at the scientific level, as I said before, the patients are different, and between men and women, then we can develop a more targeted or customized care in each center. I hope that this raises awareness to Parkinson's disease in women. But why not? We never thought of developing a center, but it could be a project for the future. The last question, maybe? There are more men than women suffering from Parkinson's disease, and I read that women would be protected up to the menopause. Well, as I was saying, some studies gave contradictory results regarding the protection of certain hormones. There were studies carried out on hormone replacement therapies in menopausal women who've shown an increase of the frequency of the disease in certain cases, and in other cases, no changes in the incidence of Parkinson. But when you talk about protection factors, it's very difficult to say whether menopause can be or not be a protection factor. There are many other factors that come into play regarding the risk for Parkinson's. And again, we don't have any epidemiological studies with a targeted objective dealing with this issue in particular, giving us any accurate answers. Thank you very much. We're going to conclude here. It's just like the Oscar ceremony. We're going to have to thank everybody. And for those of you who are online, there's a satisfaction questionnaire. We're going to ask you to answer it. For those of you who are in the room, they were put on your chairs, so you're probably sitting on them. Don't hesitate to fill them out and give them to us before you leave. It really helps us improve these meetings. The conferences are finished. I would like to thank the speakers who came, sometimes from very far. So thank you. I think that they were able to talk to the general public. So thank you very much for being present here today. We can give them a hand. And I really wanted to thank the volunteers from France Parkinson who work throughout France. Some of them were here today, and I hope you were able to talk to them and see what activities they're offering. So thanks to them for coming. Thanks to all of our France Parkinson's committees. We can applaud them as well. And I'd like to thank my colleagues who've made it possible to set up this event. Of course, you have the people who are behind the black curtain who've been here for the past 4 years. And it's really pleasant to work with them. They're very highly professional. It enables us to organize the event without any problem. And one last thank you for all of our donors and members, because if France Parkinson can finance research, it's thanks to donations. So thank you, really. And I hope that we were able to present a number of things we've been doing. If you want to know more about it, next Saturday we'll be in Paris. The researchers in the labs will be focusing on molecular and cellular research. And if you don't live anywhere near Paris, you can watch it online. Thank you to all of you who've come here, and to those who are online. You can applaud yourselves, and thank you to everyone. So we have water and biscuits. I think you've been sitting for 2 hours. It's not fruit, carrots, or apples, it's biscuits. Sweet and savory. So don't hesitate to continue walking around, and thank you again.